Hello and welcome to another episode of Hematology Horizons. My name is Elissa Baldwin. I'm the Director of National Patient Education with the Leukemia and Lymphoma Society. And today I'm joined by Dr. Sagar Lonial. He is with the Winship Cancer Institute of Emory University in Atlanta, Georgia. And we are recording on site at the Summit for Hematological Cancers in Nashville, Tennessee. So welcome, Dr. Lonial. Thank you so much for joining us today. Now, we are talking all about myeloma. Now today, your talk is on, you're giving a keynote speech, and your talk is on risk-adapted management for multiple myeloma. But before we get into that, could you explain to our listeners what myeloma is?
Yeah, multiple myeloma is a blood cancer that arises from a cell called a plasma cell. And plasma cells normally make antibody that protects you against infections or help you respond to vaccines. But in myeloma, a subset of those cells become hijacked and basically suppress normal immune function, can suppress normal bone marrow function, and can lead to fractures, and in some cases even kidney failure.
So what are the current treatments for myeloma?
Well, the treatments are significantly better than they were even 5 years ago in the context of newly diagnosed myeloma likely receiving 4 drugs as part of their initial therapy, including a monoclonal antibody like daratumumab, a proteasome inhibitor, an immunomodulatory agent like lenalidomide, and then steroids. And high-dose therapy and transplant continues to have an important role for suitable patients. And then maintenance therapy, which we now know can prolong remission and actually improve survival.
Now, your talk today was on risk-adapted management. What is that, and why is it important?
Risk-adapted treatment is really important because what we recognized almost 20 years ago was that there were some patients with high-risk myeloma, and they presented with genetics that told us their remissions tend to be shorter. And as a consequence of that, our group began a long time ago using more intensive maintenance to try and prolong that first remission. And in the intervening years, we've now identified that there are other medications we can use to also try and prolong remission. So it's the idea of not changing what you do at the very beginning, but changing what you do in the maintenance setting to try and get that longest first remission as you can.
Okay, so that frontline treatment is so important with myeloma treatment.
Absolutely, because the disease is never more sensitive than it is at the time of initial presentation. Every time myeloma comes back, there are new mutations or new genetic abnormalities that make it more difficult to treat. And so really trying to get the most mileage out of that first remission is really the key.
Okay. So what are you looking at when you're deciding, what the risk is of the myeloma patient and what they would be able to tolerate?
Yeah. I mean, the tolerance versus genetics is an important question. Fortunately, the older the patient is, the less likely they are to have high-risk genetics. And there are certain key factors that we look for, like deletion of 17p or 414 translocation, other genetic things that tell us the remission may be shorter if treated in a standard fashion. And so identifying what those are and then making sure we do every effort to try and, again, maximize that remission with more intensive therapy is how we approach it.
So is there anything that patients should know regarding risk-adapted management for their treatment? We really encourage shared decision-making with patients, so we want to make sure that they are educated about their disease and they can help make the best decisions for them.
Right. Yeah, I mean, I think the key is to understand whether you have what we would typically call standard risk myeloma or whether you have high risk myeloma. And the International Myeloma Society just redefined what it means to have high-risk myeloma. And so make sure that your doctor knows what that new definition is, because the question from the patient perspective is, am I getting the kind of maintenance therapy anybody would get, or is it being tailored to my risk? And that's really the important question.
Okay, so we really want to find treatments, though, that are tailored to the patient, correct?
That's right. That's absolutely right.
That's a great thing with these targeted treatments that are coming out, that they really can be tailored to the individual and not just kind of a blanket treatment.
That's right. That's right.
Right. Well, we hope that patients learned something today, and thank you so much, Dr. Lonial, for joining us and telling us all about your talk at this summit, and we really appreciate it, and we hope that patients will now go back to their doctors with some more information. And before we go today, I would love to know, are there any emerging therapies that you're particularly excited about for myeloma?
Well, I mean, I think we've all been really excited about the new wave of CAR T cells and using them in the right place. I think bispecifics also hold an important part of the future of myeloma therapy. And as our group has always done, we believe in combining therapies to really maximize the benefit and keep myeloma off its toes so that we can hit it with multiple targets at multiple times. And I think those are really part of the key pieces for the future.
Well, thank you again so much, Dr. Lonial, for joining us today. We really appreciate your time.
Thank you.
And thank you all for joining us as well. And we hope you join us for the next Hematology Horizons. Thank you.